Journal of OBGYN. So a lot of these recommendations are now available through the websites, and you can also see what the actual citations are on these slides, but I've summarized them together for today's presentation. So we're going to just be talking about guidance for outpatient prenatal care in the setting of the COVID-19 pandemic, and with a few slides at the end, per Richard's request, a little bit about inpatient care. And I don't have any disclosures. I'm a faculty at JABSOM, and so we're not allowed to do anything that would be a conflict of interest. Okay, so as Richard also talked about, since January, and this is data from the European Center for Disease Prevention and Control, up to yesterday, over 14 million cases of COVID-19 have been diagnosed across the world, and there's over 600,000 deaths and counting. And so as we look in the Pacific, based on the data that they have with the European Center, in the Pacific Island area, or what they call the Oceania, there's about 14,000 cases that have been diagnosed so far, with the top 5 countries as Australia, New Zealand, Guam, French Polynesia, and the Northern Mariana Islands. And this is something that Richard had touched on his slides. And then as far as deaths go, so far in our area of the world, the top 4 countries reporting deaths are going to be Australia, New Zealand, Guam, and the Northern Mariana Islands. So they excluded Hawaii and the U.S. data out of this report. All right, so as we talk about pregnancy, since that's my background, the impact on pregnancy is still limited. But the best data, the largest set that I could find that's been published in the New England Journal of this past May, was that most of our patients that are pregnant, that are showing up in a labor and delivery in New York City, luckily the the symptomatic COVID positive rate was 1.9%, and the asymptomatic rate was 13.5%. And we're very fortunate that for right now, with a lot of the stay-at-home orders, that the COVID negative patients range around 85% so far. But I'm sure this is going to be changing as the hotspots are evolving on the mainland. So the general healthcare system guiding principles that I wanted to share with the group is that the goals are still twofold, including the islands and territories that do not have any COVID. But our goal as healthcare providers is to try to reduce patient risk through healthcare exposure, and understanding that the health systems and the healthcare providers become the most common vector for transmission. It's the providers that might be traveling and bringing the infection to the island. We also need to reduce the public health burden of COVID-19 transmission through the general population by asking patients not to travel in the community unnecessarily. And so that the burden of disease makes it easier for us as healthcare providers to take care of some of the other patients that are out there. And so the first thing I'm going to be citing is this article by Bolig. And so this is in the American Journal of OBGYN. And so they are the ones that published the general guidelines out of Jefferson University in Philadelphia. And so for obstetrics considerations, the main thing we need to all remember that we're still in the middle of pandemic, even though some of our states have been opening up, we need to still prevent the spread. That's our #1 priority, which our basic principles is still social distancing. And if not feasible, get providers, get extended dividers. The plexiglass has been on a run-on right now. We're running out of plexiglass, but that's a way to try to distance patients. Any elective or non-urgent cases should be postponed. And so right now we're in Hawaii, we're in the process of opening up to elective and non-urgent cases. And so that's been a struggle. Any visit that can be done by telehealth should be done that way. And so more recently that's been relaxed and more people are coming into our hospitals, even though we've reminded everybody we need to do a lot of this by telehealth. And in the midst of the big pandemic on the East Coast, no support people were allowed to accompany the patients to outpatient settings unless they're an integral part of patient care. Here in Honolulu at Kapiolani, we've relaxed that and we're allowing one person to come in. But what happens is that without that limitation of the patients coming in by themselves, you know, the tide is breaking open and people are starting to bring in lots of other people that should not be there. And are not critical to healthcare. So we're struggling with that right now here in Honolulu. Okay, so as far as prenatal visits go, elective outpatient surgeries, have been delayed. Emergency hospital visits should not be delayed. So for people that are going to be bleeding or having an ectopic pregnancy, we don't want them to be delayed. Somebody that has a placenta previa that's bleeding, we don't want that to be delayed. However, this has made it very difficult for the healthcare providers and patients to kind of determine whether or not regular prenatal visits are either, are they really emergency or are they really elective? And because they're kind of somewhere in between. Pregnancy is a time-sensitive condition. And so we're still trying to reconcile that with the hospital system's big economic push to open up, because they're looking at the bottom line and looking at the dollars like, oh gosh, all these patients, are staying home, and so we're not making enough money. And so from a public health point of view, we've got to bring it back to, the pendulum to try to come up with a happy medium. Pregnant women, might need to be quarantined, especially if they're coming from an endemic part of the world. And this is the big battle. Women want to come in and get their ultrasounds. And so maybe not so in some of the islands that a lot of you are from, but it's very popular in the States. Like, everybody wants their ultrasound to go see the baby, but that is not a mandatory thing. And so we're having constant battles with our staff and with our patients to just bring in patients so that they can get their cute baby pictures. But if you're coming in from California and Florida, and we have a 14-day quarantine, mandatory quarantine here in Hawaii, a lot of people are starting to bend the rules on that. And so we're worried that people are going to get infected. Pregnant women may also need to be quarantined due to exposure from family members that are COVID positive, and they're quarantining in the same house. And so what do we do with those patients if they can't, if they shouldn't be coming in to see us in person? And then another issue that's coming up is that when we have these rules where patients cannot bring family members or children with them to come get their prenatal care, they may not have childcare at home. And so this is making it very hard for us as a healthcare system to decide who gets to come in and who doesn't. And so, here are some solutions that we're doing to minimize unnecessary exposure. We've been spacing out prenatal visits, and I'll show you some recommended protocols for how to space out the visits. We need to space out our waiting rooms, or have the patients wait in the car or wait outside the hospital. And so one example of the waiting room, we had to tape up the chair so nobody can sit there. And we're only allowing 2 to 3 people in the waiting room at a time. Everybody else has to wait outside or wait in the hallway or wait outside the hospital. During the initial COVID peak, we made a rule for no accompanying visitors. So the patients had to come by themselves. And that was a good rule to make. But now that they're allowing one visitor, more people are sneaking in, another child or somebody else. We're going to introduce the idea of the combined prenatal ultrasound and lab visits so that we can maximize what is being done to the patient if they do have a face-to-face visit. And that we call that the mega visit. And our family planning doctors are the ones that gave us that term. We also are trying to move towards telehealth visits. At the original peak, we were up to about 65% telehealth visits, which is actually the highest within the Hawaii Pacific Health System that I'm working in. And so they were all very proud of that, but that's since been loosened. Then there's,
Dr. Lee,
yes.
when you do a telehealth, pardon my interruption, when you do a telehealth visit, is it with a video or is it just with the phone?
It's with video. It's video. And so we've switched over to either using Zoom or using Doxy.me. And all the different hospitals have come up with their individual video type visits of the provider of that they've contracted with. The unfortunate thing with telehealth visits, it's good for consultations, but it's not so good with getting vital signs. And we're going to talk a little bit about that because, you know, as a pregnancy provider, we all want to try to get, you know, a blood pressure. We want to get a fetal heartbeat. And so there are some new potential technologies that we'd like to work on, but it's going to take a little bit of innovation and working with our IT people and compliance officers to make that work, because they're very tentative about how we can actually conduct a telehealth visit. Most internal medicine people that are doing telehealth, they have the advantage now of, you know, like the stethoscope that can listen to a heartbeat, or an otoscope that can look into an ear, but that still requires somebody like a medic on the other side to do that, to project the image over to the site. When I'm talking about telehealth, we're talking about telehealth to the home. That's patient administered telehealth. And so that's something that we would really love to work on, to help our patients. And so hybrid visits are going to be mixed, telehealth mixed with in-person visits. And one thing that we're also doing now, which was new, and the National Health Service in England is working on this too, home visitation, that instead of making the patients come in, especially if they have issues with childcare or transportation, is we have a pilot project where we're sending a midwife or a community health worker to go out and be a mobile telehealth site, but also do some of the vitals and examine the patients so that the patients don't come in to the hospital or the clinic and get exposed or expose somebody else. So home prenatal care is a new concept that we've been working on for the past 6 months. All right, so this is a wonderful protocol that the Kaiser Family Foundation put together of how you can blend traditional.
Can I interrupt, please?
Sure.
Yeah, I was just looking at your telehealth visits. So telehealth is just a one-sided thing, but when you do hybrid, it's sort of like it's sort of a mixture visit where there's two healthcare providers. One will be doing homebound, and then they just communicate from there.
Yeah. So hybrid could be like, I have a midwife that goes there and they bring an iPad, and that's like a telehealth visit where I can, as the specialist, still talk to the patient. The midwife can be there to do the vital signs. And then the two of them can talk to me at the same time through an iPad. And so they can tell me what the vital signs and the weight, and the midwife can try to listen to the patient, the heartbeat, and then, but I can be the physician provider on the other side, trying to, ask the patient question, ask the midwife questions. So that's one idea of what they call a hybrid visit. Another terminology that people use for a hybrid visit is something like this, where you alternate in-person visits with telehealth visits. So that way you actually minimize the total number of on-site in-person visits with the patient. So there's two different types of terminology that we use for the word hybrid visit. Okay, and so we recognize that, with the Kaiser Family Foundation one, not everybody can have this access of like somebody going to the home just yet, but maybe it's a program that you have available on your islands that can allow that. and just make sure you prepare them with an iPad so that they can telehealth back to the hospital or to the clinic with another healthcare provider. With the Kaiser model, this one is just to give you an example. The first two visits can be done in person because you have to get the routine prenatal blood work. But between 16 weeks and 24 weeks, then those patients can be coming in with or can do a telehealth visit, because you don't necessarily need to keep drawing blood or doing an ultrasound at that time. And it's just a check-in with the patients. One of our federally qualified health centers for a telehealth visit for those patients that have that kind of connectivity in the home, what they're doing is sending the patient home with a blood pressure cuff, an electronic blood pressure cuff, and during that visit, they can put on the blood pressure cuff and hit the button, and then they can show the provider that's in the clinic what is her blood pressure at that time. So that is kind of an easy way of getting a blood pressure, especially for a pregnant woman that you're trying to make sure they're not developing preeclampsia, to do that at home. We're also working on technology potentially where you can get the blood pressure cuff to be Bluetooth to their cell phone. A lot of our patients have cell phones. And then the Bluetooth can then be sent in to a central location where we can monitor their blood pressures. And this can also be done for, you know, diabetes. It could be done for pulse oximetry. So we're still looking at that here in Hawaii to see if we can develop a system like that. The FQHC, the clinic on Lanai, currently has the centralized system that's called CDMP, where they can monitor blood pressures remotely through a Bluetooth-enabled blood pressure cuff. In Oahu, we're not that sophisticated yet, so we're just using the one where you can just show on the TV screen. Here's my blood pressure for today. So furthermore, this is getting back to the Jefferson University model. Any questions? Somebody has another question?
Comment on what you've shared. Thank you for sharing that. You know, like it's interesting to see what you have in place in terms of the areas that we worked in. The services that we're going to give to the prenatal mothers, it depends on whatever we have, the technology and the geographical layout and what is available with us. It's just interesting. For me, I was looking at the mega visit. Mega visit is something that you know, we can adapt in terms of the services, like when prenatal comes in, all the services to be done at one time. Because over here, like the pregnant woman, they come in on a Thursday, we do, I mean on Wednesday, and then we do their draw blood and other lab workup, and they have to come back on Friday. When I was looking through this, the services that you do, I think mega visit is something that it would be interesting for us to adapt and look into. Thank you.
Right. And as we get better at doing telehealth, one of the things that we can talk about is providing support to the other clinics in the island nations and territories, so that we can help you come up with a way to do a mega visit. And I'm going to talk a little bit more about what actually happens at a mega visit that our family medicine physicians put together for pregnancy. So that's coming up in a few slides. And even in our own clinic right now, we tried to combine the prenatal visit, the ultrasound visits, and we bring in a phlebotomist, somebody to draw the blood, and also a genetic counselor. We're all stationed in one place. So therefore, like if we sometimes have patients that are flying in from a remote island, like the Big Island, they spend one day with us, and we try to do everything for them so that it's all taken care of, and then they can go back to and fly back to their own island, and their local physician does the rest. So, so we want to try to make it more efficient so that the patients don't have to fly back and forth. Because here in Hawaii, you know, there's everything, the high level healthcare is on one island. And so it makes it very difficult to, and very expensive for other people to have to fly over just to get all of this care. So we try to make it easier now so they can come and do a mega visit, and then they can go back and do the routine prenatal care. Okay, so I know we're probably very spoiled here in Honolulu, where patients are very demanding and they want all of these extra ultrasounds, which, you know, is not available at some of the smaller hospitals. But so using the high resource area recommendations is they're basically cutting, you know, some of the inpatient visits so that they combine it with the ultrasounds at the same time. But then everything else can be done, you know, via a telehealth visit or even a phone intake. And, you know, some of these visits towards the end, they don't really need so many ultrasounds. You know, like over here, people are spoiled, and if they expect 4 ultrasounds, you know, that's really not a good use of resources when we only need these 2. And then the rest can be done with telehealth and with kick counts, okay? And so, so this is also from the Kaiser Family Foundation. There are so many things that we can do with telehealth now. We just have to develop it. So besides the virtual prenatal care visits, which can be just done on a cell phone or an iPad. So this is the patient-initiated home blood pressure monitoring, or, you know, weighing themselves on a scale. We're looking at potential for a self-monitor of fetal heartbeats. That the FDA just approved, but we haven't had a chance to try to pilot it here. But I know on the mainland US, they're trying to do this home monitoring. What we're doing in place of that is kick counts, because if the patient can tell you that after 28 weeks that the baby is moving, then we know that that's a good vital sign for the baby. We're currently doing the consultations via telehealth, where you can talk to a specialist. We can do all our diabetes management via telehealth, and genetic counseling through telehealth. And that's the same thing with, you know, communication with providers versus consultations. The things that we want to try to work on more is lactation support. We're having issues, you know, with in the US and actually in Hawaii, lactation support, breastfeeding support is not covered by insurance. And so we're trying to convince our insurance companies to help pay for that, so that we can provide, you can do what's called telelactation. The University of Arkansas, you know, where they got grant money now to do a big lactation program for the Marshallese population that Richard said is very large there. And you can have lactation support to teach a mom or help a mom who's struggling with breastfeeding, so that their babies don't starve. And so we're just starting with that right now. But what we're doing instead of that is having the nurse midwife go to the homes to help with lactation support, to do that home visitation model until we can develop this as a telehealth model. Postpartum visits, most postpartum visits can be done in the home as well, so that the patient doesn't have to come in and bring their new baby and potentially exposing themselves to COVID. And so we've been doing some of these on the telephone, but if the patient needs to come in to get contraception placed, like a Nexplanon or an IUD, then they do have to come in, because we haven't been able to do that through video conferencing. And then mental health care now is moving towards telehealth, where postpartum depression, they can be seen by a psychologist through telehealth. All right, so the initial prenatal visits, if the patient can call in to say that they're pregnant, then the front desk staff can do a lot of questioning and have the provider do the visit by telephone only. They can talk about options for the pregnancy, if they want to continue with the pregnancy, the circumstances surrounding the pregnancy. They can talk about estimate dating. They can provide prescription for vitamins over the phone, and they can schedule the mega visit. So this is then the one that the patient needs to come into the clinic. We're scheduling our mega visits around 8 to 10 weeks. And that way they can come in, they can get all their blood work done, and they can get an initial clinic ultrasound by their local provider. This is not the fancy ultrasound. They can test for, do a quick ultrasound to look for viability. If they have an irregular period and we don't know how pregnant they are, we don't want everybody to check, for fetal heartbeat that early, because we know that a lot of the in the more remote clinics, they might not have an ultrasound machine, and we don't want to make that, a standard requirement in a low resource area. However, if there is the availability of a 12-week ultrasound, you can schedule a mega visit for a 12-week ultrasound, where we do this nuchal translucency screening, which can help screen for Down syndrome and heart disease and all that, congenital heart disease. I know this is not available in a lot of the Pacific Island countries. And so this is just to let you know that we're even struggling with this right now here in Honolulu, because most of our islands does not have, they don't have the availability of this. However, the people here in Honolulu are demanding this. And so it makes the ultrasounds a little bit excessive. All right, so when they come in for the mega visit, what they're doing is a complete initial prenatal assessment. They're doing the blood work, doing urine screening. They're talking about genetic screening if that's available. They're giving out aspirin, which is, recommended by the U.S. Preventive Task Force for those people that have high blood pressure or diabetes that are in the high risk category, to help as a public health measure to decrease complications during pregnancy. They can do an ultrasound if the provider has a skill, if they have a machine, and then provide instructions on doing home blood pressure monitoring. That could be coordinated with some of these home visits or phone visits. And blood pressure cuffs right now here in the in Hawaii are not paid for by insurance, and they could be expensive for patients to have. I heard that the CDC, there was a CDC grant that was awarded to the FQHCs, the health centers here in Honolulu or in Hawaii, to purchase blood pressure cuffs for patients, but that was a different grant and it wasn't for pregnancy. So we have to see if the CDC will give us another grant to take care of pregnant women and get them blood pressure cuffs. All right, so then the other mega visit is if you have access to nuchal translucency screening, that can be done with dating at the same time. And then the ultrasound for anatomy is done at 20 weeks. And then what we're doing to help our providers is, if the patient is coming in for an ultrasound, we'll do the blood pressure and the weight check and the urine dip at the time, so that, and then send the results back to the provider, so that way they can skip a visit, because we'll do that visit for them. Another principle that we're doing is trying to space out all ultrasound visits to every 4 weeks. We have some fancy patients that want to have ultrasounds every week or every other week, and that just makes it really difficult right now. And then attempt a tele-ultrasound if the patient cannot come from the neighbor island. The tele-ultrasound is an issue right now because we don't have a good way of networking live ultrasound where the high-risk OB doctor can monitor the ultrasound. There is a system that the University of Arkansas has set up that has networked the whole entire state to do tele-ultrasound. So we're trying to see if we can get the funding to reproduce that here in Hawaii, so that somebody from Maui or somebody from Hilo doesn't have to be flown over to do one of these ultrasounds. All right, so other things, this is just a review of those other slides. No worries about a dating ultrasound unless you can just do a 12-week nuchal translucency scan. Otherwise, just wait for the 20 to 22-week ultrasound where we can date it and we can look for the baby's anatomy and the health of the baby and do a prenatal visit for the patient all at the same time. The growth scans, we're trying to avoid bringing anybody back until 32 weeks where they can do a growth scan. Most people where you're doing a fundal height and the baby's, the fundus is measuring appropriate, then they don't need to come in for a growth scan. So we're trying to get people to back off on using too many extra ultrasounds that are really not necessary. This is just showing how often to be doing those growth scans. And so on the East Coast, you can see a lot of people are getting growth scans every 4 weeks, some every 6 weeks. And then non-stress tests, where we listen to the baby's heartbeat for about 20 minutes to get a heart rate tracing to help prevent stillbirth. So in general, we try to make sure that they're not getting it until after 32 weeks. And try to see if we can do it once a week versus twice a week so that the patient doesn't have to travel so frequently. With our home midwifery program, we bought the nurse midwife an NST machine where she can take it to the home of the patient and do it at the patient's home. And then what she usually does is using her cell phone, take a picture of the heart rate tracing, and then she can text it to me if she has any questions, and I'll take a look at it. There are other telehealth ways of doing remote monitoring for fetal heartbeats that right now is just too prohibitively expensive that we cannot implement. But
yeah. Oh, so I'm just unmuting.
Okay, yeah. So theoretically, it would be lovely if we could get everybody on this call to be a part of a Pacific Island fetal monitoring program so that we have a centralized location to monitor all of the fetuses. But it would take a big grant to help pay for something like that. All right, other policies that we're working with is like trying to avoid people bringing their whole family to come to the office visit. No children under 12. The visitors are usually checked, to make sure that they're not having any fevers or any other symptoms or recent travel from another country. Otherwise, they're kindly asked to either return home or wait in the car. The patients may be asked to reschedule their visits if they're insisting that they have that ultrasound or have that visitor come with them. And then the patients are being required to wear a face mask when they come to a hospital, or they will be given a mask or a face shield before being allowed entry into the clinic or the hospital. So for PPEs, this is probably a review for all of you. For regular patient contact, we're just limiting it to surgical mask, a face shield, and gloves. For a known COVID positive person or a person under investigation, the PUI that Richard talked about, then we want the N95 plus or minus, a surgical mask on top of it to prolong the use of the N95. We still have a big shortage of N95s here in Honolulu. So to extend the life of the mask, we are double masking with a regular surgical mask so that then you can throw off the surgical mask and we can reuse the N95 for as long as it is not soiled. We have been asked by our hospital to reuse the mask. A hat or head covering to cover over the face shield. Okay, sometimes we double hat. We put one hat on the bottom, we put the face shield, and then we put a second hat on top. So after we see the patient, you can take off the top hat, but you can keep the bottom hat still on so that the face shield and everything else can stay on. Where you have face shields that we were able to get 3D printed from our local schools as donations. And so we're using donated face shields. And then if not, we use goggles if we don't have a face shield. And then waterproof gown and gloves and shoe covers. So moving on to inpatient. Any questions about outpatient from the group? A few slides about inpatient work.
So just quickly, you haven't really changed the PPE requirements for a normal delivery in a patient that you don't think has COVID right now. Is that correct?
Right, right. So for a normal delivery, so we're going to talk about inpatients. Yeah, for a normal delivery, we're just using regular PPE. A known positive or a PUI, if we're still waiting for results to come back, gets the full PPE.
Are you testing every pregnant woman before she delivers?
Yes, we are. That just started a week ago. We're testing every pregnant woman that is coming into labor and delivery. And working with the labs to make sure that we get a rapid result. We know that there has been a backlog of getting the labs back in time, but yes, for especially for people that are getting scheduled inductions of labor or scheduled C-sections, they they are being required to be tested negative before they're allowed to come in for their scheduled procedures. If it's a woman that is laboring, and comes in laboring, we'll go ahead and swab them at the start, hoping that during the course of labor, their result will come back. And then and if it's negative, then regular PPE. If it's positive, then we have to do the whole uh, the level 2 PPEs.
So for the region, you folks, for the folks who are COVID free, we wouldn't recommend full gear just for normal delivery at this time. When there is community spread documented, however, like in New York City, Dr. Lee's, one of her first slides showed that for every 10 women with COVID, only 1 or maybe 2 had symptoms. The rest had no symptoms. So you couldn't really use symptoms to decide who has COVID and who doesn't have COVID. Once COVID's in your community, it's the testing, which we imagine you would have to use also rapid testing for every woman in labor so that you would know what PPE strategy and other inpatient strategies to use. Does that sound right, Dr. Lee?
Yes, yes, totally, and totally in agreement, because right now, as we know, all the PPEs, especially the N95 and the shields, they're in short supply still, and so if we can't get them, we have to save them. The same thing, and we've had heated arguments and discussions, within our healthcare system just here in Honolulu, like, what do we do? Because the hospital doles out PPEs in very, very limited quantities. And so you get one and we're told we have to use it, and that's for the duration. So we're trying to conserve as much as we can. So anyway, and we'll talk a little bit more about PPEs for labor and delivery. So COVID-19 alone is not an indication for C-section. I don't think this is an issue in the Pacific Islands, because most of the patients, you have such a low C-section rate. For the fancier patients, some people, here in Hawaii, still we have those that are coming from the mainland that want elective primary C-sections, but COVID-19 infection alone is not an indication for C-section. Principles of care, we want to minimize unnecessary exposure to other patients, which means when the patient comes in, regardless of COVID status, because while we're waiting for the COVID status to come back, they are essentially quarantined in the room, and we minimize the support person. So we don't want husbands, partners, aunties wandering around the hospital because they haven't been tested. They need to stay in the room. So we think of the room itself as a bubble, okay? Then that way, we also want to minimize unnecessary exposure to the staff. So if we have a known positive or a PUI, we'll do an initial assessment by telehealthing into the room. I thought this was really clever. We can do an interview to the patient who's in the room with maybe one provider that is a nurse with full PPE, and then the rest of the staff can talk to the patient or interview the patient from the outside. And then if vital signs need to be done, then we don the whole PPE, go in, do vital signs, and minimize it so that, it's one person doing it to minimize exposures. We've designated like a single 1 or 2 rooms that are going to be the COVID rooms, or a floor that's going to be the COVID floor or COVID unit, and then minimize transferring patients from room to room. We don't want too many rooms to get exposed to, even though we do try to do a terminal cleaning in between rooms, but why chance it? minimize, in the heat of COVID, we minimize rotations of the staff so that we were only working on what we call a holiday schedule or on-call schedule, where only half the staff are working at a time, and then the rest got to stay home for the week. And then, or 2 weeks. And at 2 weeks intervals, then we switched them over. Then the people that were home then came and worked, while the other ones that could then, you know, because it's very, very intense during a surge, and so you want to give the other people a chance to go home. So then we switch these backup teams. So we have so an outpatient team and an inpatient team. And then the other thing that we had to do was coordinate care with the anesthesiologists and ICU specialists. They did simulations like, okay, if this patient is positive, where are we going to move her? Who does what, so that we minimize contact and we minimize exposures. Yeah, and everybody learns to coordinate, you know, who does what, so that you don't have an accidental exposure. All right, so this back to the Richard's comment about the PPE and labor and delivery. So, and this is also from the Philadelphia Jefferson group. So they published a second article on inpatient care. So what we are assuming is that when a patient is in second stage and pushing, that's considered aerosol generating, because, you know, when the patients are going, okay, that's releasing the air droplets. And so that's why labor delivery itself is considered a high risk period of time, as well as intubation. So if the patient is getting a C-section under general anesthesia, that is also a high risk for exposure for the staff. And so, so if there's in labor or they're having a C-section under general anesthesia, everybody needs to get the N95s on. And particularly for those that are known positives, as Richard was saying. Okay, but if you're test negative in your community has a high enough COVID background rate that's positive, then move towards testing them before they come in, or testing them while as soon as they show up. And if they're COVID negative, then you can just use the regular surgical mask. Okay. But if they're known positive, then you have to then do the N95s and everything else. So full PPE if the patient undergoes a C-section with general anesthesia, that's a known positive. And then terminal cleaning of the operating rooms and kept empty for 2 hours. This was a recommendation from Bellevue Hospital in New York City, because when they were in the heat of it. I don't know if, like in the smaller hospitals, that we can afford to keep a room, you know, unused for 2 hours. And so we don't really follow that here. But if you have a big COVID surge, this was what they were doing in New York City, just to allow the ventilation and the HEPA filters and, you know, everything else to kind of suck up the virus, so that the room would be clean enough for the next patient. All right, other things. Okay, so we are doing universal screening of patients with timely results, because if the results take 2 weeks to come back, that's not going to help for somebody that's in labor. Scheduled inductions and C-sections are getting screened before they're allowed in the hospital for their elective procedure. If the patient is a known positive or a PUI, we try to get them in a negative pressure room. Okay, well, the fancy hospital where I am here in Honolulu, we do not have a negative air pressure room in the operating room. So what we've substituted is a HEPA filter machine in the operating room, and with the hopes that it's sucking up all the virus. No visitors, obviously, and then PPE for all staff in the room. Originally, when during COVID, when it first hit, they were only giving PPEs to the doctors, but not the nurses. And so we made a big push that if the nurse is going to be in the room pushing with the
Lee, may we have a question, please?
Pardon?
Dr. Lee, may we have a question? Can we have a question, please? This is Kushai.
Yes, go ahead, Coach
Yeah,
Rai.
Yeah, with the HEPA filter machine in the room, is that the same as the air filter machine?
Yes, yes, yes.
Okay.
Right.
Thank you.
You're welcome. Yeah, so we made sure that the nurses also were getting N95 masks. And then this is just a kind of demonstration that you want a negative air pressure room where all the particles stay in the room, not a positive pressure room where all of the air particles can spread to the other patients in the other rooms. Okay. All right, the CDC does not recommend separation of the mother and the baby. So this is, you know, now moving towards after the baby comes out. The mother can be kept with the baby. If the mother wants to be breastfeeding and she's COVID positive or PUI, then she needs to wear a mask to feed her baby. Because you can't really separate them if the baby's going to be going home with them, especially if the mother is asymptomatic. Okay. Then you know the baby's going to be allowed to go home with the mother. Obviously, if the mother is in critical care in ICU, then yeah, she's going to be separated from the baby because she's not going to be able to do anything to take care of the baby until she's well enough to have the baby be with her. All right, that's all I have. So these are just some examples of, so for postpartum care, there's a tele-NICU. So for this, here's a very sick mother, and she's checking on her baby, who's obviously a preemie baby. University of Arkansas has this. I've tried to get the NICU here in Honolulu to purchase a system like this so that mothers can see their babies even while they're sick. But this gets to be expensive, so we don't have that. And then this is just a reminder that if you're breastfeeding and the mom is positive, then put on a mask. We still want the fathers to be involved, so make sure that they're putting on their masks. But then the best, you know, prevention right now is with Baby Yoda is to wear your mask and do your best to stay at home. And thank you, and I'll take any other questions.
Love the Baby Yoda. That's nice. This is the way. I have a question about vertical transmission. I understand it's been reported, but it's very rare. Can you comment on that?
So there's one case of a true report, and that case report came out last week. Really amazing job of the team that did it. I think it was in Italy or somewhere in Europe. They sampled this was a C-section on a patient that was a known positive. So they sampled the amniotic fluid, they sampled the placentas, and it was a scheduled C-section. And so the fluid came back positive, the placenta was positive. And so we think this is rare because all of the other patients that we've, CDC and the other epidemiologists have been following, all the babies have come back negative. But they did not do this type of detailed screening of the amniotic fluid and the placentas. So this might be another project that we could think about for us here in the Pacific, because I know during Zika, you know, we collect, you know, all the placentas were collected and sent to the CDC for monitoring, but this might be something that we could actually do locally here in Hawaii, if that's something that folks here want to do, so that we can actually calculate what a true, you know, transmission and how, and look at the risk factors for like who is actually transmitting to their fetuses. For the most part, the babies are staying with their mothers. There's no other transmission that we've seen locally to, at least in Hawaii, to any babies. We are seeing more positive moms that are coming over now and being admitted. And so they are being tracked in a registry by the pediatricians. But we're not getting a whole lot of feedback right now as far as, you know, what's happening, because our numbers continue to be so low for pregnancy in comparison to what's happening on the mainland.
I did see a recent CDC study with over 8,000 women, and it showed that the babies are doing pretty well, but the moms actually with COVID are at a higher risk.
Yes.
They're clearly at a higher risk for hospitalization, but they weren't able to really sort out if the hospitalization was because they were pregnant or because they were sick. But if you look at their admission to the ICU, there's at least a doubling of the risk of a pregnant woman needing to go to ICU The
Higher?
mortality was not higher than others, but the risk of being severely ill was higher, and the risk of being ventilated was higher. And this was also greatly affected by the presence of gestational diabetes. So once again, for all of us, we are reminded that the communities in the Pacific are certainly high risk
Right.
due to
And we want to be
non-communicable disease.
reassuring to our patients that they are at a higher risk for getting severe disease, but the mortality is not higher. And so, and we do want patients to come and get care, but we don't want them to overdo it and let their guard down and get, be unnecessarily exposed. And so I think, so we want, it's this balance of like scaring them, but not scaring them, and providing, providing the exact amount of care without being overly, wasting money and resources for care, but not scaring them enough that they all decide to do home births, which is another problem here in Hawaii. They're going off the grid and they're delivering, in a jungle somewhere on the Big Island, and then we never track them and we never hear about them. So so that's an issue. And then there was another paper that came out recently that reported that in Europe and in Netherlands, they're noticing a decrease in preemies. So there's a decrease in prematurity during the time of COVID compared to pre-COVID. And so I doubt that these patients are delivering at home, especially not in Europe. But whatever is happening, maybe sociologically, with patients being asked to stay at home, that's, or there might be decreased stress, decrease in transportation and having to travel around, that this confinement, bed rest is actually improving outcomes and less exposure to the harmful things that the medical people do with excessive testing and trying to like scare everybody. So I posed the question to our labor and delivery nurses to see if we can look at our own data to see. I mean, it's probably not going to be as visual here because our COVID rates are so low, but that's another thing that, in a lower resource setting where everybody has to be at home and be with their families, that's probably better. And that might help to decrease prematurity.
Are there other questions from the region?
Yes.
For Dr. Lee, please go ahead, Coach.
Yeah, this is Debbie. Debbie from Palau. Can you hear me?
Yes.
We can. Go
Yeah.
ahead.
Yeah, this is Debbie. I'm the OBGYN in Palau, and I have two questions. My first question is the transmission in order to do a cesarean section, do we have to consider the incubation of what part of incubation period is the mother in? Does that affect our how we're going to go about delivering the baby?
Okay. So
That's number one question. Depending on what time of incubation period, does it matter? That's the first question. The second question is, has there been, I know the study in Wuhan for the cesarean section, there was no amniotic fluid, virus in the amniotic fluid, but they did not do the vaginal fluid. Has there been a study for to see if there is any virus in the vaginal fluid? So we can really confirm that to do a vaginal delivery is really safe? Those are my two questions.
Yeah. Okay. All right. Let's talk about the intubation side. So during the intubation, when the whole, this is from an anesthesia point of view, the whole thing where you're ventilating and then you're mass ventilating and then you're putting the tube in and the patient sometimes coughing, right? That whole intubation period of time could be, extruding, particulate air particles and droplets, nuclei into the space where other people are being exposed, whether or not it's going to be your pediatrician that's waiting for the baby or the doctors and nurses that are in the room. And so that's why, from the CDC point of view and the American College of OBGYN is reserve C-sections, not to prevent transmission, reserve C-sections only for your usual reasons. Like, if the patient, the fetus, the baby is getting stuck, failure to progress, or if the mom is critical with COVID and she's in the middle of coding, you can do a perimortem C-section to get the baby out so that they can ventilate and do CPR on the mom. Okay. Otherwise, do not do routine C-sections just to prevent COVID from transmitting to the baby.
So there's no difference if the mom was on day, let's say day 8 versus day 14?
To do a C-section?
Yes. I'm kind of, I'm trying to kind of gear toward the load, the viral load. Does it matter?
That's a really, really good question. If the patient is critically ill, right? We assume that's going to be the time where they have the highest viral load. However, I don't think that anybody knows in the course of an infection, like if the patient gets a COVID swab test today, that day 5 or day 9, she's going to have more or less viral load. I don't think anybody's done that. However, what I try to find out is like, if somebody is a COVID positive, asymptomatic COVID positive, how long do we wait before re-swabbing her or allowing her to come into the hospital or clinic for a care? And so right now the recommendations are still it's 14 days. So what the viral load is in between, I don't think anybody knows. Richard, would you know?
Well, sure. I mean, they have begun to look at those studies and look at the cloud around someone if they're symptomatic and they have viral loads into day 5 or 6 or 7 when they typically have a higher viral load. But I don't. To answer the question, I think that in the midst of a decision to do a C-section, that's driven by the mother and the baby, irregardless of the presence of COVID, and then the COVID restrictions and requirements for PPE are put in place, regardless of whether someone is, as long as they're tested positive, I think you have to safely presume that they're infectious and take those precautions with a safe intubation, hopefully in a negative flow situation, and then quickly get to surgery if she needs that surgery. So
Okay.
I think that would be the answer. The second question, Dr. Lee?
Oh, well, in addition to your first question, so for instance, if the patient is on day 5 after her initial infection positive test, and the baby's having decelerations, and you assume like she has a high viral load, you're still going to need to do the C-section to get that baby out to save the baby.
Right.
Don't worry about the viral load. Just do the C-section, but do it safely with PPE for everybody that's going to be in the room. Okay. Now, the second question, what was the second question?
The second question was, I'm kind of referring back to the Wuhan study where they did check the amniotic fluid for the viral loads, but they never did the vaginal swab to check the virus. So can you comment on that? Has there been anything done? Anybody done the study on vaginal swab to know if there's virus or no?
Yeah, I don't think anybody's done that. Richard, do you know?
No, I don't think the study's been done, but you can presume that it would be positive. If someone was highly infectious, they would be viremic and likely positive in vaginal secretions. We do know this, and that the outcomes from those babies is quite good. And whether that means the baby was not infected or the baby was infected and did fine, because kids remarkably, for the most part, are doing really well with this. That would take some research. That study may have been done to see how many babies actually born vaginally are showing evidence of seropositivity later. I don't know what the answer is. And again, they could be sharing mom's antibodies. And so it'd be really complicated test to do right now without a good antigen test. So yeah, we don't know, but we do know that those babies are doing very well. Vaginal delivery is still by far the best choice for a COVID infected mother. Would you agree with that, Dr. Lee?
Correct. And also, if you just look anecdotally at the discordant couples, where one couple is positive, the other couple is negative, you know, you presume that you can only presume that they were intimate, and so there's not reported sexual transmission for right now. That it's all, you know, respiratory transmission.
Right. Good point.
Okay.
Right. So,
Very good point.
So I would doubt that there's virus in the secretions. Otherwise, you would see more
Yeah,
sexual
good point.
transmission.
Yeah, that sounds right.
The other thing is, I think it's believed that the babies are getting, especially the other case that was the new case that was reported that was in the amniotic fluid. So they're thinking that that's going to be hematogenous spread, right? Because that's how it's going to get in to the baby through the placenta and the umbilical cord. So, so that's like if the mom was extremely viremic, and the viral particles are in her blood, and then it gets over to the baby. And so that was what you know, was presumed in that this other recent case.
Which led me to the third question. I'm sorry, but my third question is like, if the mom was infected, how long does it take for the baby to develop their antibodies toward the virus? So if we did a cesarean when the mom was still, the viral load is very high, there during the incubation period, has the baby developed antibiotic during that time?
The baby would be getting antibodies from the mother at the time. The baby would not necessarily develop its own antibodies just yet.
Yeah, but then what I think my point is the mom is still infected, so we don't assume the mom has started developing their antibiotic, right?
Right.
So we assume that the baby hasn't got the antibiotic from the mom because the mom is still being infected.
Okay.
I guess my question revolves around that.
Okay. So if we look at other models of viral infection, okay, so let's see. There are other models of viral infection that if the mom was acutely infected and viremic and doesn't have antibodies, and then the baby would then catch it and they would get sick, right? If the baby were to develop their own antibodies, the baby, if it was like a new inoculum, like the baby got it, you know, after delivery when the mom was holding it and the mom was breathing on it, then, you know, the baby would develop antibodies the same as any other infant developing antibodies. It takes about like 4 weeks for the baby to get antibodies. So the pediatricians would have to keep monitoring the baby to make sure that it wasn't developing a severe form of the infection. And then the other thing that's new from the mainland is for the young children that are developing COVID infection. So this is like toddlers and school-age children. They're developing something that's resembling a Kawasaki disease. So massive total body inflammation, you know, of the blood vessels. And so that's currently being monitored right now because everybody says, oh yeah, no, the kids are doing fine. They can go back to school. Everything's fine. But there is a rise in this systemic inflammatory syndrome that the babies are seeing. So that's why the pediatricians do need to keep an eye on them. You can't just like let them go just yet, but they do need to go for their well child visits.
Right.
I'm afraid in the interest of time, we will have,
Thank you.
we can have time for one more quick question, and then we need to move on to the next speaker.
No.
Go ahead.
Although we are still a COVID-free island, but once the border is open, we might be anticipating COVID patients. Are you recommending routine testing for term pregnant women so that at least we can more or less anticipate what PPE we are using during labor and delivery?
Yeah, that's a really tough question. It just depends on your access to resources and the number and your availability of tests on your island. So right now,
It's a lot.
they have a lot.
Mm-hmm.
Oh, then you can create that for your own cohort. I wish we had more, because right now we're limiting it only to patients that are having a scheduled C-section or a scheduled induction of labor. They need to get one within 72 hours, because you don't want to do a test 1 week ahead and then they catch it in between, right? So you want to get it close enough to their C-section date or induction date as possible. And they do the outpatient drive-through testing, and then once the result comes back, the day before, then they'll allow them to come in to do to the hospital for their induction of labor. For the regular women that are wandering around, waiting for their due date and waiting for labor, we don't swab all of them because we don't have the swab capacity on our island. So we just wait till they show up because we don't know when they're going to go into labor. All right. Okay.
But if we have enough, maybe we can do it routinely, for our own protection as providers.
Yeah. You have enough.
Maybe not until you've demonstrated some community that the virus is present in your community. I mean, you could do it now because the numbers are small, but in general, it won't be useful until you know that you have COVID somewhere in your community, and then that would be the time to do universal testing of women close to term. Or
Yeah,
maybe...
don't waste it now. Wait till you have COVID, and then you can enough COVID to then make the screening worthwhile. But if you don't have COVID, save it for later, because these tests are really hard to come by.
Yes, that's true.
You can even share them with us.
Yes.
No way. No, we're not sharing them. Dr. Lee, I can't thank you enough for this excellent talk. It was so grounded and focused. We really appreciate it. And a reminder to our listeners that all of these slides will be available on the PIHO website, possibly even later this afternoon. Okay. But unfortunately, we're going to move on.
And I need to go back and go see patients, but thank you so much for letting me join in, and hopefully we can do more talks, because I love this kind of stuff.
Okay, thank you again.
Thank you.
So that was fantastic. Once again, I'd like to introduce Dr. Macias, Dr. Patricia Macias from Cook County, who is an assistant professor at Rush and in the Division of Pulmonary and Critical Care. And of course, the most important thing on her CV is that she was a key helper for the TB-free Mazureau, and we shared a beach house that is supposed to sleep, I think was supposed to sleep 6, and we had 16 sleeping on the floor in a beach house in Ajotake for a few weeks. So we enjoyed, all of us, getting to know each other while we worked on reducing TB and Mazureau. But this is about going from the COVID-19 in the beginning of life to COVID-19 in the end of life. And at this point, would love to turn the screen over to Dr. Macias.
Okay, let me just get ready, okay?
Thank you. We know we're probably going to go over here, folks. It's hang with us as you can,
Can you see it?
Not yet.
Not yet. Okay, hold on a second. Let me just go back. I was doing fine until now.
Click on that green button and...
Right. Let me just go. I think I got it. There we go. So the Zoom. I lost it. Hold on a second.
Yeah, sometimes the icon goes hiding and you have to make it.
Okay. Can you see? Almost there. Huh.
Yeah.
Okay. Share.
Oh, good. We're there.
We almost there. Okay, there we
Perfect.
go. Ah, finally. Sorry about that.
No,
All right.
that's great. Thank you, Dr. Macias. We can hear you and see your slides just fine. Please proceed.
Great. Well, hello again. I'm Patricia Macias. I'm a pulmonary doctor working at Cook County Hospital in Chicago, and I have no conflict of interest to declare. And sorry, going back there. So we're going to be talking management of COVID-19 disease cases. And after that amazing presentation of Dr. Lee, it's going to be a very difficult act to follow. I'll do my best. So important thing for you to know is I am not a medical examiner. However, I did develop this with the help of our medical examiner at Cook County. So we're going to be talking about consideration of handling disease cases with COVID. Also how to prepare, pack the bodies for transport to autopsies, mortuary, crematories, and burial sites. How to prevent exposure in autopsy environments. Also, the recommendations from the CDC for funeral homes. How to handle the bodies in funeral homes. And finally, we're going to talk briefly about repatriation of human remains. So I'm going to be talking about the WHO guidelines on the bottom of the slides. You're going to see all the resources I used. So first of all, we have to remember that COVID-19 is such a new disease that we don't know much. We're still learning. So it's important that we use most of the precautions and be very careful to avoid any complications, obviously. However, I guess we all know that usually dead bodies are not going to be the source of infection. Of course, we know there are exceptions to the rule, like for instance, the hemorrhagic fevers, Ebola, and Marburg virus disease. And everybody remembers cholera, that's another big one. And some people that die with influenza, they might actually retain some viable viruses in their lungs. So during autopsy, those bodies could actually become infectious for people performing the autopsy. But up to now, there are no evidence, or there is nothing that we actually can say that anybody has been infected by being in the same place, the same body with somebody that died with COVID-19. So far, there are no reports, okay? So the CDC wants to remind us that the idea that we had to cremate anybody that has had a communicable disease is really wrong. It's just a myth. Basically, cremation should be a matter of cultural choice and religious choice. And it's also related to availability because they're expensive in some places. All right, so let's just talk briefly about how to handle disease cases. Before we start handling the body, it's important that we need to make sure we have the available supplies. So Dr. Lee explained that very clearly before, so I'm not gonna go through that. She did a very good job. And also throughout the past presentation, we talk about that. But everybody has to have a PPE, period. Also, nowadays, there is such a large amount of people dying, unfortunately, but we have to remember that we have to keep the dignity of the dead person, and we have to respect the cultural and religious traditions. It is very important that we protect their family and their beliefs, and we just don't try to just, get rid of the body as soon as possible, move it out. We have to be very respectful about that, okay? Once we have the body with us and, in the morgue, usually comes to the hospital morgue in my settings, but it could be in the city morgue. So we have to balance this very, very fine line. We had to assess the case by case. What is the need for us to know the cause of death? What are the risks for the staff to be exposed to an infection in these procedures that are very aerosol generating, just like Dr. Lee just explained? These procedures are very, very high generators of all these small materials. And also the rights of the family to know what the loved one died from. So we had to balance all these important issues. So it is important, obviously, that when we're interacting with the body, as I said, we have to always use standard precautions. Again, Dr. Lee talked about using PPEs, and all of them, had to use a full gown, gloves, the whole thing. Especially when we're gonna be doing these procedures that are gonna be splashing and showing all these body fluids, secretions and blood and all these problems. So we had to wear a facial covering, goggles, face shields, and N95 masks. So people that are gonna go into an autopsy area should not be just using a surgical mask. They're gonna have to use an N95 or any kind of respirator to avoid inhaling all those aerosols. The WHO says that it's better, you have to remove all the catheters and everything of the body, obviously. And the WHO recommends that it's important to obviously get all the bodies, all the orifices well contained so we don't have any leakage. But I guess those are just guidelines for everybody. The WHO says, please keep the handling of the body to minimal. Don't move him a lot. And they also recommend to try to transfer the body to a morgue as soon as possible or to a mortuary area. They feel that there is no need to disinfect the body after the body has been actually wrapped in a cloth, because I recommend to wrap the body in a cloth. And they feel that there is no need to have a body bag. And if you feel that the body is going to be leaking a lot, then a body bag will be useful. They also feel that there is no need for a specific transportation for this. On some of these points, the CDC differs, and we'll talk about the CDC guidelines in a few minutes, okay? So to prepare the body in the mortuary or the autopsy or the crematorium or whatever, the staff needs to wear a full N95 when they are actually washing the body or tying the hair or shaving or doing any kind of preparation for the viewing. They still need to wear a full PPE, that is gloves, a waterproof disposable gowns, or apron, and obviously masks and eye protection. And if the family agrees to only view the body, they have to instruct not to touch the body, to use standard precautions, meaning if they're gonna come to the funeral home or wherever they're gonna be viewed the body, you have to have hand hygiene, and again, not to kiss the body, not to interact at all with the body. Anybody that is immunocompromised, that is anybody over 60 years of age, should not interact with the body because obviously they have more chances of complications. And the WHO feels that embalming is not recommended because they are afraid it's going to cause a lot of aerosolized materials. They said manipulation of the body is not recommended. And I put a small, tiny note in the bottom. It says IDPH recommends otherwise. IDPH is the Illinois Department of Public Health because we follow the CDC guidelines. All right. So anybody that dies with COVID-19 might still have some live viruses, viable viruses. Some of the people asking questions to Dr. Lee were asking about, you know, have they been doing all these studies? How long have they stayed there? I don't think we know yet because COVID-19 is so new. So if they're gonna do a procedure like embalming or a autopsy, this has, again, they had to wear an N95 and the whole 9 yard, because they're gonna have a lot of aerosol generating procedures. You're gonna be using power saws or washing the intestines. This is for the autopsies. So they have very high risk of infection, contamination. So the mortuary or the pathologist or the medical examiner, whoever is in charge of the area, has the duty to assess the risks of getting a postmortem study. And because it is not going to be safe for them or for the colleagues, most likely they shouldn't proceed with the autopsy. So if we know that the person died with COVID-19 is confirmed, then the autopsy is not necessary. And actually that's what we're doing at Cook County in Chicago. And I think they were doing the same thing in all these places with very, very high mortality. The medical certificate, the medical examiner was issuing the medical certificate right at the time of death, because they knew what the patient died from and they would avoid these procedures. However, what if the person died from something else, or we don't know what the patient died from? Either in the hospital, they came from the emergency room and they died there, or they died at home. So do we need to know the cause of death? Well, in that case, if we think the person might have died with COVID, then the sampling has to be limited to only that. So what they're doing at Cook County is they're actually swabbing. They're doing the nasopharyngeal swab in the bodies, and they analyze them. If the COVID-19 is verified, that's it. They issue their certificate and they avoid the autopsy. So these are the CDC, which are the Illinois Department of Public Health recommendations for funeral homes. So according to the CDC, there is no risk for anybody being in the same room at a funeral home or a visiting service with somebody who died with COVID. However, there are some restrictions. Okay, so anybody that has symptoms or is known to have COVID will not be able to attend the funeral or the viewing, because we don't want it to spread COVID-19 among the people visiting or being in the funeral home. And that is a bummer. It's really bad, because the relatives or friends that were living in the same household of the person that died will not be able to attend the funeral for 14 days. They are quarantined. And that is a really big problem. I think somebody talked earlier in the talks about how difficult this problem is, because family are not allowed into the hospitals. And now we're talking about they're not allowed to see their loved ones in the funeral homes. I mean, this is really a very emotional and problematic issue, obviously. However, the funeral homes are becoming more, they're actually becoming more resourceful. So they're actually doing remote services, just like we're doing it now, with Zoom or any other kind of technology. Or they can actually record the funeral service so the family and the friends can view it later on. The same applies for also from the burial. So this is funeral homes, viewings, and burials, okay? No more than 10 people can be present at a time. Again, this is a big problem. But let's just make a small pause here. If this is for countries this is for places, cities like, for instance, Chicago or any place in the States, anywhere in the country right now, where COVID is running, rampant everywhere. But countries that are COVID-free, this might not be applicable, okay? But some of these might be applicable. But right now, the CDC recommends no more than 10 people at a time in a viewing or in a burial site. In the gravesite site is the same. Only 10 people are allowed to be present. And everybody going to see their loved one are not allowed to touch the body. Obviously, they cannot hug them, kiss them, and definitely they won't be allowed to be washing or cleaning the body, etc. And obviously, anybody that is older people or immunocompromised should definitely not be close to the body at all. Again, all this is really bad, and that's why this is not a difficult situation, but it's also a very sad situation for everybody. This is an important issue for everybody, especially for the Pacific area, which is embalming. So remember, the WHO says no embalming, but the CDC says, oh yeah, you can definitely do embalming. However, you have to use standard precautions. And the people doing the embalming they have to wear full PPEs, including face shields and goggles and N95s, obviously. They had to use this, as I said, the respiratory protection, whatever needed. And don't know if all the morgues have negative pressure rooms, but Dr. Lee did talk about the environment. They're also standing in a closed environment for 2 hours. Actually, we'll talk about in a few seconds. Actually, there are some studies already that show they might stay up to 3 hours in the environment. So it is a problem. So they need to wear heavy-duty gloves. And those heavy-duty gloves had to be over the disposable gloves. And this is because these procedures are very high risk for cuts, puncture wounds, and injuries, skin breaks, all this. So they had to be extremely careful. And obviously all this has to be waterproof. And they had to follow the aerosol generation procedures. They had to follow the guidelines. And I put this resource there. That link is the CDC. I strongly recommend to go through all the resources I have there, because they have a lot of information that you're gonna find very useful. So this is how to guidance for postmortem specimens for the CDC. All right, so this is another important issue. All these funeral workers, when they're going to the home of somebody that has died, they don't know at that time if somebody in the household has COVID, if they know or not if the person died with COVID-19. So they are very high risk. So these are the first responders, kind of the first responders, so they're very high risk too. So they have to wear complete PPEs. That includes, gowns, that includes gloves, that includes respirators. And obviously they had to follow all the standard precautions. The transportation of the body has to be done in a body bag. That's what the CDC recommends. And that's what everybody's doing here. They want to make sure that there is no leakage, there is no splashing, and so they prefer to have a body bag. And the CDC recommends to disinfect the outside of the bag. This is different from the recommendations of the WHO. So they go, okay, place the body bag and then spray it out. Spray with any kind of disinfectant that is against COVID-19. So this is very important to try to minimize the spread of the infection. And as I said, everything is, you have to wear all the PPEs. What about the body bags? Can they be reused? And yes, some of them are able to be reused. However, they had to be thoroughly cleaned and disinfected, and they had to follow exactly what the proper instructions from the manufacturer are, but they have to be very carefully disinfected. And when handling the bag, the worker in the funeral home or morgue or whatever, they have to wear a full PPE because they don't want to be splashed with whatever was some remains of some of the fluids from the body. All right, so after they remove the PPE, this is for the funeral home, all the healthcare workers also, they need to wash their hands with soap and water. The 20 seconds that everybody has heard, that's what the highest recommendations from the CDC, 20 seconds. But if for some reason there is no water or soap available, then they should use hand sanitizer. The CDC recommends a hand sanitizer more than 60% alcohol solution, or some of the other solutions that we discussed previously, and we're going to talk about them in a second, to like a chlorine solution to disinfect them. The problem is this: you are very lucky. You don't have cases right now there, and some of those cases in some of the other areas in the Pacific areas are very, very small. But in mainline, the situation is not good, obviously. So to preserve many bodies, it's important to place them in some kind of refrigeration. And they can remain in this refrigeration for about, they have to be kept about 37 to 40 degrees Fahrenheit to keep them, cold. And the problem is that the morgues get full really fast. So what to do? Well, then they can use refrigerator trailers. A refrigerator trailer can hold up to 30 to 40 bodies. And they can actually keep them in the trailer for up to 60 days if needed. In the background of this picture, you see these boxes? Those are actually trailers. Those are refrigerator trailers. This is one of the improvised morgues that New York City had. You can see the Statue of Liberty right on the background. Of course, warehouses, that have refrigerator facilities, they can hold a lot of much bodies. The medical examiner of Chicago was explaining them that they were able to keep between 300 to 400 bodies in one of the meat packing refrigerators in Cook County. So yes, we did have also some of the refrigerator trailers that you can see there, that's like New York City, but we were able to use some of the meat packing because the Chicago used to be a traditional meat packing area, so they have all those available up to now. Of course, countries with very large number of people dying, they are using now mass graves, and you can see that on the news everywhere in the world. And obviously New York City is not an exception. They also use the Hart Island, which is an island that is just off of Manhattan and still being used as a mass grave. And it's still open and still in use now. All right, so Dr. Lee was talking about this briefly, and this is a study that came from the New England Journal of Medicine. They were actually looking about the COVID-19 lifespan in common surfaces. And this is important for this topic because we'll just talk in a second why. So this is, air means aerosols, okay? So we know that aerosol, the COVID can stay there for up to 3 hours. She was talking about the 2 hours that is actually in the OR, but according to the New England, can stay up to 3 hours. In copper, can stay 4 hours. Look, cardboard can stay 1 full day. And as you see in between stainless steel and plastic, up to 3 days. So this is very important. And it's very important because when people die, they leave belongings behind. And most people don't toss them away, right? So what to do with them? Well, if they're clothing, so what they can do is they can soak them in hot water and soap, and they should stick to kind of move them around for a while. And then after, you know, about an hour or so, just get them out, wear gloves, get them out, and get them out to dry on the sun. Have to be very well dried. And then, or you can use the chlorine disinfectant that we talked last time about how to mix that, and we'll talk about this again. You place them there for, it's a 0.5%. This is kind of a weak disinfectant. And you just place them there for about 30 minutes and then just get them out and put them on the sun to be dried. So what about those objects that are not clothing? Well, so for them, you want to use something stronger. You want to use a 1% bleach, a 1% chlorine, okay? So you can use also soap and water if you don't want to use bleach. And or you can use alcohol, but if you're going to use alcohol, it has to be more than 70% ethanol that you're going to use to spray to disinfect. So here, last time we showed this, and it's back to you again, is how to mix a mild 0.05% chlorine solution. And as you can see in the bottom of this picture, there is somebody washing their hands. So the CDC says, go ahead, use it. You can actually clean your hands with this. And so I put right here on the bottom, I put some note that says the household bleach usually is about 2.25% is the regular strength. Please make sure that if you're gonna give this information to your patients, they know not to use the ultra strength chlorine, which is very strong. They just do all the mixing with the 5% chlorine. Same question. No problem. Is there a question? I guess not, right? Okay. Can you still hear me? All right.
Yes, we can hear you fine. Please continue.
All right, very good. Now, this is how to mix the 0.1% chlorine solution, okay? So this is the one, remember, this is the one that is not to use in your hands. By the way, going back to the hand, this other one, the 0.5% for the hands, I had used it. It's not easy on your skin. I recommend the alcohol better, but if you don't have that or just wash with soap and water, this is good enough, obviously, okay? But they're not easy in your hands. Now, the 0.1% is very strong in your skin, so wear gloves. Please don't use it to you know, for your hands or anything else. So this is how you're gonna mix it. This is the one you're gonna use to disinfect the surfaces and the utensils, remember? All right, so let's just talk briefly about the remains, repatriation of remains. So this is actually put together from, I got this together from the, it's called the International Aviation Transportation Agency, which put this paper in collaboration with the WHO, the CDC, the International Air, the Association, and the International Civil Aviation Organization. So basically they said that there are 3 possible options to transport human remains by air, because we're talking mostly about air. It's more difficult to do it by sea or land. I guess everybody's doing it by air. So the easiest one is cremation. It's very easy to put on in an urn and take it with you, right? It's less complicated, but obviously that depends on personal, cultural, and religious, preferences. So that's going to be a very personal thing. Now, embalming. Embalming is probably the safest thing to do. And when the body is embalmed, it has to be placed on a body bag. And the CDC and the Illinois Department of Public Health uses double bag. They said double bag those bodies. And the coffin has to be sealed. So it is very important that it's going to be transported. Now, it says here this option may be challenging since every state has different options or laws. Okay, so when I was hearing Dr. B's introduction, he was talking about Arkansas, Washington, and California. So I went back fast and I Googled. So Arkansas law does require the body to be embalmed before being transported. That is, it has to be embalmed if the body is not going to be, disposed to wherever to the final destination within 24 hours. So if the body is not going to be buried or anything else, the body has to be embalmed or refrigerated, except if the body is being cremated right away. Okay. Now, Washington is exactly the same law. I'll review it, okay? California, however, the law says it's optional. You may actually, if you don't want to do embalming, there is no need, but then embalming is recommended. So I guess you're gonna have to, depending where the human remains is coming from, you're gonna have to kind of figure out, what's gonna be happening with the states. Those non-embalming is pretty much, the transportation is very similar to bodies that are embalmed, which there had to be in a body bag, double bag, sealed coffin, and then this transportation will vary from country to state or state to country, because not every state would allow you to import or export a non-embalmed remain. Now, if you go here in the resource that I attach, which is basically this guidance information from the International Aviation Transportation, then you just scroll down and then you're gonna see there's a list of, there's some countries in the appendix. Now, of course, I couldn't find all your countries, but I saw, okay, here, so an idea. Cook Islands, they require the body to be embalmed, okay? You go also the Fiji. Fiji also requires the body to be embalmed. And so I saw another one, there we go. Samoa. Samoa requires the body to be embalmed. However, if the body is not gonna be embalmed, then it requires a special permit. And so those are things that you need to keep in mind when you're going to talk about repatriation of the human remains. And, oh, sorry, there we go. And this is a very important slide. It's really busy, but it has everything you need to know, okay? All the postmortem guidelines, all burial sites, all the guidelines from postmortem from the CDC. They also had, you also included WHO guidelines and the other guidelines that I just found there. So please take time to review them. Oh, here, this is actually some of the products, how to use the hand rub that I introduced this last time when I was talking to you about people that are discharged from the hospital. And this is actually how to mix alcohol swabs, okay? Sorry, alcohol hand sanitizer, because it's a lot easier to use in the skin than the chlorine. And with that, I was short and sweet. I hope I can answer any questions. Again, I'm not a medical examiner, but I can help. If I can help to answer any questions, I'd be happy to do it.
Okay, are there any questions?
Yeah, this is Dr. Skillen from Kochai. May I ask some questions?
Yes, please.
Yes. My first, thank you very much. It is so very clear, and thank you for the resources that you have put up for us to look up. Being out here, we usually don't embalm the body if they're going to be buried on site unless they wait for relatives to come from abroad, which is almost impossible at the moment, but we do receive embalmed remains from the United States. My first question is, I know you know that the mass grave on Hart Island in New York, but people there don't go fishing. So my question for the community of Kochai is there a guideline for how far away from the river or the seashore that the burial of remains for a COVID positive person be buried? I know we had really big issues with the burial of people with HIV/AIDS, so I just wanted to bring that up. That's the first question. And the second question, I didn't catch it. I assume that because the coffins will be sealed, we're not allowed to open them after they are arrived on the island, correct?
That is correct. So let me just answer the last question first, because I'm not sure about the first question, but let me ask the last question first. Yes, what I was told by my medical examiner is they double bag the body, then they transport in the seal coffin, and I think I had a picture here on the background. And then once it arrives to this destination, obviously the funeral home will get the body out and will prepare for the viewing, right? And so the reason I got the other slide showing the lifespan of the virus in surfaces is because that's the question: how long the virus remains viable in the body? And right now, I could not find any study right now showing that, and I asked that to the medical examiner, and she couldn't answer that. She says that if they proceed with an autopsy right away, and within 24 hours or less than 48 hours, that they assume there might be some viable viruses. But she wasn't sure that that was the case if the person has been dead for a week or so. And so in food for thought, it might be okay. Remember what I said on the funeral homes and the burial sites, that the CDC says no more than 10 people. But this is not because of the body. Remember what the CDC and the WHO says, there are not really any, up to now, any evidence that the bodies per se are infectious. We're talking about COVID-19 only, right? So, so far, nobody has been infected by being in the same place with a person dying with COVID-19. So if the person arrives in the Pacific Island after being dead, and I assume it will be after more than a couple of days, because it's gonna be a lot of red tape that has to be done, then perhaps the viewing will be safe and people can actually do the funeral home without problems wherever they're gonna go in the Pacific area, without having the 10 people cut off. But of course, she strongly recommended not to touch the body. Don't touch the body, don't kiss the body, don't hug the body. It's the safest thing to do until we know more about COVID-19, because remember, we don't know much about it. Now, about the first question, I am not sure. Sorry, I didn't show this to you guys, but I actually included, just in case a curveball was tossed at me, okay? So this is a site, this is actually information of the law for the main line. And this is actually put out by the, one of the, I guess it's one of the consulates or embassies in Samoa. And I'm gonna send this to Dr. B. And go ahead and also use this because you have the resources, you have the phone number, and you have the web page and the email address. So you can ask some of these questions. I'm sure they will be able to answer this better than me, especially about how far a burial site should be. Anybody has any other question?
Thank you. I just wanted to add that we do not have funeral homes. So in a sense, we will just receive the remains still from airport to wherever the place, the home or whatever, to the burial site. We do not have funeral homes. Nobody will open the coffin. And for the burial sites, we do not have memorial gardens. So everybody bury their remains outside their homes, whether it be in the hills or on the shoreline. That's why I was asking. And thank you for trying to answer. And I'm sure we'll try to look up also in the resources that you have sent us. Thank you. Over.
Okay. Thank you for the comment. And you're right. When I was in Majuro, I remember that. I remember everybody burying their loved ones in their backyard. And I thought that was actually very touching. I thought it was really nice to have your loved ones next to you forever. That's actually a very good idea, I think. But yeah, I guess if you're not gonna open the coffin that is already sealed, it will be even safer for everybody. That's my impression.
It seems like the bottom line is that in terms of infection, the risk is not from the relatives who passed away. The risk is for the relatives who are there at the funeral with you. That's where you're going to get your risk for COVID. And it's important to remember that, I think.
Yeah, absolutely. So as I said, this is probably not applicable for people that are in countries that are COVID-free, because the issue is the people that have the symptoms, not the body. The body will be okay. As long as you don't touch it, you'll be safe. Again, if the body comes from the airport to the house of where the final, destination is gonna be, where the burial is gonna be, and the coffin is not gonna be open, then I don't think it will be any problem because everything has completely sealed and it will be safe. Anybody has any other question for me? Well, okay. I guess in that case, well, thank you very much. And I hope that this was useful for everybody. And I will send all the information to Dr. B as well, okay?
Dr. Macias, thank you again. And you did double duty there to do two tough topics and presented them both with clarity, and was grounded and very useful for us. The comments in the chats are really quite supportive of the presentation, and the fact that you have really helped us move forward on these issues. Thank you. So to finish, a reminder that next week we will be talking about update on the labs. We'll try to focus on both the RT-PCRs that you have, as well, for many of you have, as well as the ID Now and Gene Expert that all of you have. And then an interesting talk, a vaccine update, which I think would be interesting for all of us. As there's been progress, this will be a tough talk to keep up with because there's so much progress. And this is really the bottom line for all of us, I think. And finally, I'd like to end on something a little bit light. In terms of our signage for everyone, here's a sign for Alaskans. How to social distance for Alaskans: 3 sockeye salmons, 1 large snowplow, that's 6 feet, or 7 pairs of snow boots. We're thinking today about how to do this for Pacific Islanders, right? Do this island style. So we're thinking maybe 1 proa, right? 3 sea turtles, that's about 6 feet, or of course, making sure we include everybody, 2 large beer coolers. That should be the distance that everyone has to stay away from each other. So with that bit of silliness, I think we'll close for the day. Thank you all very much. We've gone over again, but we hope your questions and your interaction make this successful. We hope to have be able to finish this out next week and the week after. All right. Thank you all.
Thank you.